This is in sync with the recommendations internationally. So the International Evidence-Based Guideline 2018 for the assessment and management of PCOS recommends that lifestyle management, which includes both diet and exercise, is the first line of management, especially for the overweight and the obese patients. And especially in the infertility patients with PCOS, the treatment principle is to optimize the health status with lifestyle management before the therapy begins. Now, there are evidences which suggest that a well-adjusted and individualized and a balanced diet is very beneficial for ameliorating the metabolic disorder and fertility. And it also prevents the future pregnancy-related complications. We very well know that there is an adverse impact of excess weight gain in obese PCOS and the potential predisposition to weight gain in lean PCOS patients. And this is very important because of the unique body composition of Asian Indians. There has been a data which establishes that as Indians, with thin fat Indians with higher obesity, and it is not different among the PCOS patients whether lean or obese. This is a very interesting study which was done by Satyadri and group in Tamil Nadu. They identified the difference in the body composition among the lean PCOS and the obese PCOS vis-a-vis the counterparts. It's very interesting to know that the PCOS patients, whether lean or obese, are metabolically worse as compared to their counterparts of the same BMI and the same age. The interesting part is even the patients who are lean have a similar amount of visceral adipose tissue as compared to the obese, and they're different from their other counterparts who are non-obese. So what is more common and what is more similar makes us define the differences in the nutritional management of the treatment. These similarities and differences actually decide the nutritional goals for both. However, the common nutritional goals remain improving insulin sensitivity, fertility, decreasing the visceral fat, reducing the inflammation, hyperandrogenism, correcting the hormonal imbalance. So what is different in two management treatment therapies? It's the weight management. For those who are obese, weight loss is very, very important. Along with that, the decrease in the truncal fat and waist circumference helps in regularizing the menstrual cycle. So hypocaloric diet will help him by reducing the macronutrients and managing the disorders if they all have, like binge eating or emotional and stress eating. On the other side, when you look at the lean PCOS patient, what is more important is to avoid the weight gain and maintain the body which they have. And at the same time, ensure that the patients do not gain fat mass and help them lose that as well by giving them an eucaloric diet which is rich in micronutrients. So now if you look individually at the lean PCOS patient, how do we achieve this though the underlying condition remains insulin resistance in them? It's important to change the macronutrient composition, which means change the composition in diet in terms of carbohydrates, proteins and fats. Increase the amount of fruits and vegetables in the diet. Provide a diet which is similar to Mediterranean diet, which is rich in which is more of an anti-inflammatory diet, and supplement them with calcium and vitamin D. My previous speaker was going to discuss a lot about calcium and vitamin D, but I leave it here that they are very important in regularizing the menstrual cycles and reversing the insulin resistance. However, the exact dietary macro and micronutrient combination are still undetermined, and this was published in the previous year. So what does a Mediterranean diet look like? It may not be only for those living in the Mediterranean diet, which can be modified by Indian patient, but it should be more or less similar to these lines of giving a plant-based, nutritionally balanced diet, including lots and lots of whole grains, legumes, fruits and vegetables, nuts, and a daily intake of olive oil, which usually is not common in Indian diet. The olive oil comes only as a salad dressing in once or twice a recipe. But in a Mediterranean diet, the focus is on the omega-3 acids coming from the olive oil. A lower glycemic index carbohydrate fiber-rich diet, moderate intake of animal protein coming from fish and poultry, low consumption of saturated fatty acids from dairy, red meat and other processed meats. Moderate consumption of wine is usually common in the Mediterranean diet. Overall, this is an antioxidant rich diet for us. So for a lean patient, what is important? The diet has to be nutrient dense and not calorie dense. We are trying to maintain their weight and reduce the visceral obesity. Now coming to the obese women, now when we nutritionally try to manage this, we understand these women are suffering from the intrinsic insulin resistance plus the obesity related extrinsic insulin resistance. So most important is to manage weight loss. even a 5 to 10% of weight loss can improve insulin sensitivity, improve the hyperandrogenism, reproductive outcomes, and many more benefits. What is equally important is to reduce the fat mass and increase the lean body mass, because that is what is going to increase the energy expenditure and improve the hormonal and metabolic parameters. So for these patients, to achieve weight loss, most extremely important is to create a negative energy balance, and that is by restricting the calories in the diet on a daily basis by reducing 500 to 1000 kilocalories. That is nearly 30% of what they eat. More or less it would be around 1200 to 1500 kilocalorie diet will help them achieve a weight loss of 0.1 to 1 kg per on a weekly basis. Now what is interesting is it's not only the number of calories. The reduction in the calories promotes effective and sustainable weight loss irrespective of the macronutrient composition. No matter how much of carb, protein and fat you distribute, if the calories is lesser than what they eat by 30%, they will achieve weight loss. And this is achieved by increasing the amount of vegetables and fruits in the diet and by providing supplements of vitamin D and inositol as discussed by my previous speaker earlier. So basically for weight loss of the obese patients, couple of diets which have really worked beautifully is a Mediterranean diet, which I've already explained, a low GI diet which mainly focus on the type of carbohydrates, which is basically those which do not increase the blood sugar levels immediately post consumption. So foods which are high in fiber, high in protein would be low GI foods such as non-starchy vegetables and whole grains. What works the best in these obese patients is a hypocaloric diet. It could be either through diet only or it could be by the use of meal replacers or supplementation as well. So irrespective of that. Now the next question is, does the dietary intervention only improve the weight in both the cases obese and lean, or is there a role for diet in ameliorating the reproductive sequelae associated with this low grade inflammatory PCOS? So the answer is yes, because both the diets, Mediterranean diets and low carb diets, have showed improved reproductive outcomes, not only reducing the percentage of fat in the body, but also improves the pregnancy rates and lowers the risk of miscarriages. The hypocaloric diet on the other side also have similar effects on the body, not only improving in the insulin sensitivity and regulating the glucose metabolism, but also studies have shown that they improve the sex hormone binding globulin and also reduces the free testosterone. The key here is for those obese women who do not have regular cycles, if they follow hypocaloric diet, the cycles will get regulated only after 6 months of intervention, not within 1 or 2 months of intervention. Minimum 6 to 12 months of intervention will help them regularize the menstrual cycle. So while planning a diet, we consider the quantity and quality of all macronutrients, carb, proteins, fat, good fats, and the time and the meal of eating. And this is important because we as a country are a carb eating nation with more than 67% of carbohydrates, in whichever state we are. It's a huge carb based diet with very less protein coming in throughout the day, whether it is only in the milk or cup of tea. Usually we do not have a milk based tea in all cities, it's more like a cutting chai. So the amount of milk used is not more than 30 to 50 ml, or it could be katori of dahi in the smallest katori in the dabba, or at the dinner time it will be 2-3 spoons of curd without a water in the form of a chas or a buttermilk. So and even the non-vegetarians limit their intake of non-vegetarian foods to maybe on no Mangalwar, no Shanivar, and no some other days. So the limitations are there in terms of protein intake in a diet. So it's very important to consider the type of carb, because we are a carb nation. What kind of a carb intake does the patient have? We know that certain foods which are high in glycemic index, the entire load of the meal will increase the fasting and the postprandial blood glucose level and worsen the hyperinsulinemia and insulin resistance. So there are studies which have shown that giving a diet high in carbohydrates will increase not only weight or metabolic parameters, but also have a negative reproductive outcome in terms of total testosterone and low SHBG. Now this is very interesting, that studies which show that refined sugars, which rapidly elevate the blood sugars, and ART success rates are very low among those women who regularly consume foods which are rich in refined sugar. Because many patients say, I take only half cup of sugar in that, then they have a little bit of sweet in the evening, and then some of them also start their day with a glass of water with honey in it. So if you see that the consumption of simple sugars is quite high throughout the day. On the contrary, the intake of whole grain produces a thicker endometrium, which in turn increases the implantation success rate. So choice of carbohydrates also make are very important. So in this study where they decrease the amount of carbohydrates in the same calories in both the groups, 1800, if you reduce the carbohydrates from 55%, that's almost half the plate, to 41%, there's an improvement in the metabolic and reproductive outcomes. Also lowers the amount of body total fat. So this is not only for obese, even for the lean PCOS where obese visceral fat is on the higher side. Selection of the low glycemic index foods is very important. I'll just explain you with an example. Poha, which is a high glycemic index food, which is a rice-based product. The glycemic index of this meal would be high. But if the patient is encouraged to add peanuts in this, to add a little bit of coconut in it, to add some vegetables in it, we are going to reduce the glycemic load of that particular poha. So we are eating the same traditional food, but reducing the glycemic load of this meal. That is very, very critical in selecting the type of meal that we give it to, irrespective of the number of calories over there. So you can use this kind of a chart, you can take the picture, and this can be given to the patient so that they can make the best choices. They must choose those which are in green and blue, that is low or moderate GI, and avoid the foods which belong to the category of high GI. And there are several studies to prove that, which I am not showing here. Another important thing, because carbohydrates and proteins have the similar caloric value of 4 kilocalories per gram, it's important to replace the proteins for carbohydrates because we are poor protein nation. And by increasing the proteins and replacing it with carbohydrates, we are also able to increase the lean body mass and reduce the abdominal fat, which is very important in both lean and obese PCOS. So it is very important to the diets must not only look at the weight loss but also improve blood glucose metabolism. And it's very easy. For those who are non-vegetarians, we know that they can opt for eggs or a lean chicken or fish. But for those who are vegetarians, class 1 or the complete protein is soy protein, which can be included in the diet, or use the dals extensively and in each meal. So they can add it to the atta, they can add it to the vegetable they are cooking, they can use low-fat paneer or curd in each meal, add these commercially available milk powders and soy powders in each meal to increase the protein content. And surprisingly, we always assume that nuts are high in fat, but nuts are one of the richest source of proteins as well. So inclusion of nuts in every dish which is prepared. Like I said, poha, you can add some peanuts, you can add some almonds and walnuts to it, or that will lead not only the good quality protein, but also fat in it, because selection of fats is also very important. I'm not going to talk about all fats, but only those fats which we need to focus on is omega-3, because these increase the reproductive outcome by increasing the progesterone, improving the embryo quality and implantation rates. Especially using of fish oil and flaxseed oils have shown a lot of benefits. What you need to avoid is trans fat, because even 2% of energy coming from trans fats is going to increase the ovulatory infertility by a great 94%. So make sure that you suggest your patients stick to these cooking oils: groundnut oil, rice bran, olive, mustard, canola and soybean oil will take care of the proportion of omega-3, omega-6 in the diet. It's very easy to suggest and some changes to them. Just a few examples here. Suppose the patient is taking a high glycemic index fruit like chiku, you can suggest a low GI fruit like an apple. The sweet lassi and glucose biscuits which we usually take in the evening may have high simple sugar, move it to nuts. So slight changes can help them. Changing the ingredient also matters a lot, especially in Maharashtra and Gujarat, where dokla is commonly eaten for breakfast, which is rice based. If you change the ingredient from rice or rava to a sprouts moong in it, you will improve the protein quality and also the fiber quality and lower GI in terms of carbohydrate. Similarly, change the method of cooking. Instead of frying, you can do steam with it. So you can use the same traditional foods in a different method. One plate which every patient must be shown is this my plate, okay, where what we usually eat is on the left hand side, where major proportion comes from the rice and the chapatis. They should keep 50% of vegetables in the plate as compared to the rice and chapati. And worse, when the clock strikes 6, you don't know what to do. Whether lean, especially the lean patients I have seen, they tend to eat because they think they're of normal BMI, so they will order for samosas and bhajiyas because they don't have to lose weight. But we know the adverse effects. So suggesting them healthy snacks is a better option. Among all the better options which I mentioned here, giving them a meal replacement drink is also an upcoming option that we have now. Last couple of slides which talk about probiotics. I think tomorrow we have a whole big session on the gut dysbiosis and its role in the pathogenesis of PCOS. So I'm not going to deliberate upon that. But what I will only share is what probiotic foods you can recommend to your patients. So those probiotics which are available in the liquid form or the powder form or tablet form can be given, but those foods which are similar to having a probiotic effect, which are the fermented foods such as fermented tea, fermented dairy, fermented sauerkraut or cabbage, can be given to patients as probiotics. Only 2 lines about vitamin D, that we know today vitamin D increases the endometrial receptivity and implantation, and the deficiency is reported to have a negative effect on the egg and the embryo quality. So giving vitamin D supplements, because there's no food which can give vitamin D except the fortified vitamin D. So supplementation plays an important role. So is zinc. A lot of people have taken a zinc during the COVID times. A lot of women got pregnant also during that time. So it also proves that zinc plays an important role, not only in the folate cycle, but also in the oocyte maturation. So a multivitamin or a zinc supplement may be in additional to the nutritional recommendation given to that. This last slide is just to show this result of this meta-analysis of 28 RCTs. This was published 3 days back in a Journal of Nutrition Review, where they examined the impact of the carbs, the low carb diet, DASH diet, GI diet, and supplements on 40 different outcomes in the women with PCOS. What I want to say is, irrespective of the composition of carb, protein, fat, the other things which we generally fail to give in a diet also have a beneficial outcome, like probiotics, which pro and prebiotics, which is a symbiotic, use of curcumin supplements, use of fish oil supplements, omega-3 supplements, use of vitamin D supplements, and inositol as and when required. So it's a joint effort of the dietitian and the doctor to suggest them the nutritional supplements. Lastly, an easy slide for all of you as a take-home slide. What diet will you give it to a PCOS patient, whether lean or obese? Understanding all the principles which I've shared before. 4 to 5 meals a day, not like every 2 hours or not even a 2-meal day pattern, a balanced meal, a variety from each food group, a low carb diet, especially low in glycemic index, protein in all the meals, replace the carbohydrates with proteins, use good quality fats, include nuts, include N3 fatty acids, reduce the intake of packaged, preserved, saturated and trans fats in the diet, drink enough water, stick to low calorie beverages or a low fat milk or vitamin D fortified soy beverages. And finally, the use of probiotics and prebiotics should be there in every diet sheet of a PCOS patient. And this is important because every patient may not have an access to a dietitian, and every clinic may not have a dietitian attached to it. So overall, the diet is an effective intervention for improving fertility. Thus, professional and dynamic dietary advice should be offered to all PCOS patients, especially obese who will become lean or lose weight. The dynamics of the nutrition plan changes and must continue till the patient achieves pregnancy and post-pregnancy. With these last words, I thank everyone for their patient hearing. Thank you so much.